Where does OT fit in psoriatic arthritis care? In my opinion, we are currently underutilized in arthritis treatment, even though you'll find OT embedded in this comprehensive psoriatic arthritis treatment guideline, which we will be reviewing today. In this 1-hour CEU course, we'll review this guideline, which will help you brush up on psoriatic arthritis care, see OT within a holistic approach to care, and appreciate the importance of individualized care. After we review the article, we'll be joined by Duana Russell-Thomas, MSOT, OTD, OTRL. Her and I will discuss her innovative approach to arthritis care through a self-management program and the funding that has made this possible. Her story, coupled with this guideline, will leave you with practical takeaways for improving your care of psoriatic arthritis. So let's dive in. Welcome to the OT Potential Podcast, where we review new and influential OT-related journal articles, then bring on an expert guest to help us pull out actionable takeaways that you can implement in your practice starting today. Welcome to the podcast. I'm your host, Sarah Lyon, OTRL. And before we dive into this topic of OT and psoriatic arthritis, I wanted to let you know that this podcast may count as continuing education for you. You are probably listening to this podcast on a free platform, but to gain CEU credit, you will need to be a member of the OT Potential Club, our OT evidence-based practice platform. It is $89 to sign up for the club, and when you do so, you'll be able to log in, take a test, and earn a certificate for your time today. So bearing in mind that this could count as a continuing education course, I wanted to state our 2 learning objectives so you can be thinking about them throughout the course today. Our first learning objective is that you will be able to recognize assessments that OTs can utilize with psoriatic arthritis patients. Our second is you will be able to identify the components of a self-management approach to OT treatment for psoriatic arthritis. So let's begin by looking at our journal article, and then we'll bring on Duana to discuss how this could play out in your practice. So the article that we are looking at today is called the American College of Rheumatology / National Psoriasis Foundation Guideline for the Treatment of Psoriatic Arthritis. This article comes to us from the Journal of Arthritis and Rheumatology. It was published in 2019, and it is ranked 4th on our list of the 100 most influential OT-related journal articles. So this article begins with just a refresher for us on what is psoriatic arthritis. Psoriatic arthritis is an autoimmune disease, which means the body's immune system mistakenly attacks healthy tissue. This results in chronic inflammation, which in turn causes pain and tissue damage. I wanted to note too that in some cases, psoriasis is a standalone diagnosis, which causes red, itchy, and scaly patches that are most commonly seen on the knees, elbows, trunk, and scalp. So psoriatic arthritis then occurs when these skin issues manifest alongside arthritis of the joints. Usually the skin issues appear before the joint issues do. In some patients, however, the skin and joint dysfunction appear at the same time. And in 10 to 15% of patients, arthritis presents before the skin issues do. In many cases, psoriatic arthritis flare-ups are punctuated by periods of remission. Ultimately, psoriatic arthritis is associated with negative impacts to health-related quality of life as well as high healthcare costs. Greater disease activity is associated with greater joint damage and higher mortality. So digging a little deeper into the manifestations, there were multiple terms in this section where I definitely needed a refresher. So just high level, joint pain, stiffness, and swelling in combination with psoriasis are the main symptoms of psoriatic arthritis. But the specific joints that are impacted and the degree of that impact can vary quite a bit. So here are just 5 of the terms that the article talks about to highlight some of the specific manifestations of the psoriatic arthritis. The first is dactylitis or sausage fingers, and this is severe swelling in the fingers and or toes. Next is enthesitis, which is inflammation at the site where a tendon or ligament inserts into a bone. Next is onycholysis, which is the painful detachment of the nail from the nail bed, usually starting at the tips and or the sides. Next is arthritis mutilans. This is a really rare form of psoriatic arthritis that causes severe damage to the bone tissue. And this form of arthritis is sometimes called opera glass hand or telescopic finger. And last is spondyloarthritis. This is an umbrella term for a family of closely related diseases that share common features, chief among them being inflammatory arthritis in the spine and other joints. So PSA fits under this umbrella, and I'll link to the foundation, which I think is a helpful resource for seeing how the different kinds of arthritis are related to each other. So is psoriatic arthritis curable? Unfortunately, psoriatic arthritis is not curable. However, early identification of psoriatic arthritis and early initiation of therapy can both improve long-term outcomes. Pharmacological and non-pharmacological interventions can help relieve the symptoms, and they can occasionally result in remission of the disease. As researchers have learned more about the various presentations of psoriatic arthritis, more and more treatment options have been developed. However, there has been a clear lack of research-backed guidance to help clinicians decide which treatment path might be best, which is where this paper comes in. So how does this paper contribute to our understanding of treatment for psoriatic arthritis? The intent of this paper was to compile evidence-based treatment recommendations for the management of active psoriatic arthritis in adults. These recommendations were developed by the American College of Rheumatology with support from the National Psoriasis Foundation. The article goes in depth on the development of the guidelines, which involved a massive literature review followed by a panel vote to assess the strength of the recommendations. The panel was composed of psoriatic arthritis experts and of patients. And of note, I want to say that guidelines specifically for the skin psoriasis were developed separately with the American Academy of Dermatology. I will also link to those. So which assessments were mentioned in this article? At this time, there is no widely agreed upon standards for defining psoriatic arthritis disease severity. The guideline states that providers must judge severity on a case-by-case basis. However, there are some helpful charts in this article, which I encourage you to look at. They're on page 9. And they did mention 3 separate assessments that I want to highlight: the Psoriasis Area and Severity Index, the Minimal Disease Activity, and the Disease Activity in Psoriatic Arthritis. So which medications did they recommend? Let me start by saying that this is a really long and convoluted section. So for the purposes of this podcast, I'm going to refer you directly to the article. I'll also link to some other easier to read articles that just give you the high level overview of the available medications. I do want to note though that the article recommends a treat to target approach, which is gaining traction for several arthritic conditions. So shifting to what we want to know as OTs, what did they recommend for non-pharmacological interventions? This is where occupational therapy comes in. It is recommended that, as tolerated, patients with active psoriatic arthritis use some form or combination of exercise, physical therapy, occupational therapy, massage therapy, and/or acupuncture. Looking at the specific recommendations they lay out in this section, they have one strong recommendation, which is based on moderate evidence, and that is smoking cessation over no smoking cessation. So that was their strongest recommendation. And then the next couple of recommendations were deemed conditional, meaning that due to lower levels of evidence, healthcare providers and patients should discuss the associated interventions and implement them on a case-by-case basis. So they had 3 conditional recommendations based on low evidence, and that was OT over no OT. And they specifically said that recommendation is conditional based on patient preference, out-of-pocket cost, distance to OT site, and access to transportation. Other conditional recommendations were exercise and weight loss. Then conditional recommendations based on very low evidence were PT, low-impact exercise like Tai Chi, yoga, and swimming over high-impact exercise like running, massage therapy, and acupuncture. So headed into the discussion, in the discussions, the authors rehashed these recommendations, emphasizing that the patients on the panel strongly valued therapies that prevented future damage, improved quality of life, social participation and function, and were safe. Patients were particularly wary of interventions that created adverse events leading to decreased quality of life, such as fatigue, nausea, and malaise. Lastly, it is important to note that of the many recommendations they listed, only 6% were strong recommendations. The other 94% were conditional based on lower levels of evidence. This indicates the importance of active discussion between the provider and the patient to choose the optimal treatment. So I really loved this article. I think it did a good job orienting us to psoriatic arthritis and then orienting us to the many forms of treatment and what we know and don't know, both about the condition and about treatment. But what it left me wanting to know more of is what can OT look like as this recommended service. And that is why I am so thankful to be bringing on our guest today, Duana Russell-Thomas. Duana is an assistant professor of occupational therapy and medicine and the director of the Community Experiential Learning Center. The center serves the community's needs by actively engaging in the health and well-being of St. Louis residents. Duana earned her bachelor's degree in psychology in 1992, her master's degree in occupational therapy in 1997, and her post-professional doctorate in occupational therapy in 2016 from Washington University in St. Louis. She earned her Master of Arts in Professional Studies from Eden Theological Seminary in St. Louis in 2021. Since 2010, Duana has led the Arthritis Center of Eastern Missouri, one of 7 regional centers designed to offer arthritis-friendly physical activity and self-management programs. She is a chronic disease management program and diabetes self-management master trainer and a pain self-management program leader. Her leadership roles have included serving as the president of the National Black Occupational Therapy Caucus since 2019 and has been an active participant in the American Occupational Therapy Association and the Missouri Black Occupational Therapy Caucus. So without further ado, I will patch Duana into this podcast. Welcome to the podcast, Duana. It's great to have you.
Thank you. Thank you for having me.
I am so thankful that you are here to talk about this topic. I know as OTs, we so often have people on our caseloads who have arthritis, but not enough time are we specifically treating that arthritis. So I'm excited to talk more specifically about that and then hopefully end with how we can just get more involved in this really important practice area. But before we go there, I want to learn just a little bit more about you and about how you first found OT.
All right. Well, that was quite an experience because I had no idea about OT until I was a freshman in college. And I had someone who lived next door to me who was doing the 3-2 program with Washington University. She had a big poster up, and I started asking questions because the poster just looks like so much fun. And I've got that fun-loving personality. I wanted to do healthcare. I wanted to do something totally different. So that opened the door for me to start asking questions about OT, and it had the flexibility that I wanted in a career, and it allowed me to use, so I was a psychology major, and it allowed me to use all these pieces of psychology and my dance background and arts and all of these things I could put together and actually help someone to be healthy. I said, I've got to take a look at it. So a lot of other exploration that came along with that. But that's how I found out about occupational therapy all the way in the college years.
I just from talking to you during the prep, I can so see how your personality was drawn to occupational therapy. And that's interesting to hear about your dance background too, which I think is an interesting interplay with the idea of arthritis and then how you became interested in OT and arthritis care. When did that happen in your journey?
Well, I would say that with older adults, there were community-based groups that we started getting into. And so think about the fact that I've been practicing for over 20 years, right? So community-based OT was a little bit newer. And I had older adults who were community dwelling that needed activities to do. And a lot of them had arthritis. And what better way, I think, to engage that but through movement.
Mm-hmm.
And so we would put on, culturally relevant music and that kind of thing. And and I incorporated music into the groups instead of just your typical exercises that could assist with range of motion and things of that nature, kind of combat fatigue, all of that. So that was my way of being able to take something that an occupation that they were interested in, and then incorporating it in a way that we could address some of the symptoms of their arthritis and even mood.
Hmm.
Yeah.
Some of my favorite memories in OT definitely involved dance. I'm the worst dancer in the world, but I love having that movement component, and I totally see the value there. When you were doing those community-based groups, what was the structure and funding at the time? I'm curious about that.
Well, they were, I don't remember if we had external funding. It was definitely something that the program in occupational therapy funded other faculty members at the time to do these community based groups. And I had the opportunity to plan and then implement those groups. I was in between being a student and then moving into my early years of practice. And now that I think about it, I do recall one of the faculty members having a grant affiliated not directly with arthritis, but with isolation and older adults and helping people to age well in the community. And so at a certain point, it switched, and I believe we had funding there.
I can totally see how you get this experience in working with adults in groups, and how that
Yeah.
sets the stage for where you go then from to then be involved in the arthritis centers. Can you tell us? I guess I have a two-part question. If you'd be willing to share a little bit about your own personal experience with arthritis, and then what your work has looked like with the arthritis centers.
Okay. Well, for me, I actually was diagnosed with osteoarthritis. Ooh, maybe in my 20s.
Oh, super early.
So it
Oh,
was
I didn't
super
know
early.
that.
It was yes. So and it was odd. They asked if I had lots of injuries or different things, and of course I have the history of dance. So I just attributed the issues to dance. But then when I said, "Well, what's wrong with my hands, though?"
Yeah,
It's just
yeah.
my hands weren't the large limbs that were moving around. So I became aware, but I didn't worry about it a whole lot. My family members have arthritis. Arthritis is all around us in the world, right? It's very normalized. And so I will say though that at some point during my experience in the doctoral program in OT, and while I was also working, I had so much pain that I started like looking into the literature to see what's out there. And self management was this new concept at the time. And I said, oh, there are ways to maybe manage my condition. So that's how I ended up being interested in arthritis, because it was a personal issue for me and also my family members. When you get down to the arthritis centers, so the CDC funds programs like evidence-based self-management programs to be disseminated throughout the state. And so I'm in Missouri, and I became one of the coordinators of what we call regional arthritis centers. There are different regions that we all work together to cover the state. But that's how I became involved through the self-management. I was interested in self-management. People found out about it and they said, OT seems like a good fit for that. OT, will you apply for this funding? And I did. And so we disseminated programs through, I guess, through the program in occupational therapy at WashU.
Mm. Wow, that's amazing how all those things came together. Your personal experience, your work experience of doing groups with adults, and then to be
Hmm.
connected to this funding source that probably not enough people know about, and then to be exposed to self management really early. Like
Yeah.
now there's such a literature, but it sounds like you were there, or were an early adopter of it.
Yes, as a matter of fact, some people, quick funny story. I was in the doctoral program. They said do a micro teach about something that you're really interested in. I said I'm interested in myself
Yeah,
and
yeah.
and how to
Yeah,
manage
how do I
as
get
an
rid of this
OT, how to
pain?
manage some of these symptoms. And that I ended up creating this really like 5 or 10 minute teaching session, and people asked, "Did you create the term self management? That's really cool." And I said,
Yeah.
"No." So that's how new it was,
Yeah.
is that people didn't, we weren't even, it wasn't something that they recognized. So it was, it ended up being a great connection for me.
So, what did this program at the Regional Arthritis Center look like? Is it virtual? Is it group based? What are you teaching through it?
Well, so it's heavily scripted because it's evidence based, and it's been disseminated not only, the states that have this funding, but throughout the world. It's in different languages. It's really popular work, and it's the program lasts over 6 weeks. There are usually maybe 8 to 12 people who make up an ideal size group from the community, and the way sessions go is that it's very OT like, in that the peers often help each other problem solve things that they want to do, goals that they want to achieve. But it's all around doing micro teaches where you share a little bit of education, and then there's a little practice about the tool that they just learned for symptom management. Learn a little bit more, practice a little bit more. You make goals each session, and everybody shares about their goals. You come back the next session starting with feedback on how you did in trying to achieve your goal, and you can solicit help from other peers in order to figure out, there's another way that I could have achieved that if I didn't meet it. And it continues this process, and so it's actually the people learning the process of being able to manage their symptoms and live well, as opposed to just hearing the information and not figuring out how to implement those techniques into their lives. Yeah,
Wow, that
it's
program.
very very community
Yes,
friendly,
yeah.
very OT
I can
friendly.
so see why
Hmm.
that would be effective. The like learning plus action plus community plus goal setting, feedback on those goals. It just feels like it's all there. I wish all chronic diseases had that kind of support. If someone was curious to see that protocol, is that
Hmm.
available? Is that something I can link to for people to see?
Yes, as a matter of fact, there's a newer website. It's the Self Management Resource Center. So I do believe it's smrc.org. I'll have to double check that, but lots of resources there. If someone was actually, because there are programs that are for chronic disease in general. They used to be specifically for arthritis, and then there was a discovery that a lot of people who have other chronic diseases like diabetes, heart diseases, those kind of things, also have arthritis. And so the symptoms are similar. So you may see lots of different programs that are there, but the resources are, I believe, powerful. And they have videos and different things that will allow someone to see more in depth about how the programs are, I guess,
Hmm.
implemented.
Yeah, from my perspective of looking high level at the research in all these different areas, arthritis seems unique and special where there's a lot of research done, there's a lot of protocols. And so then it's strange to me that not enough OTs work explicitly in this area because there's so many tools out there for us.
Yes.
I wasn't planning to ask this, but I can't help. I'm curious for on your own arthritis journey, what have you taken away from these groups? Like what changes have you made? How have they, I would think they would affect you so much as the facilitator.
Absolutely, which is why I keep
Yeah.
doing them. As a matter of fact, we've gotten to the point where because they're very scripted, we have opportunities to give feedback to the at the national level and to have changes made, whether it's from us or from participants. But being an OT, And I progress every time that I lead a training, training other people to be able to do the class, or every time that I lead and another peer group, I take away something. I make my goals. We make goals as leaders.
Hmm.
And we're going through the process every single time. And just at the time where I need a little boost, I get a chance to deliver another class. And it just reminds me of pacing, that pacing is okay. Um, that it encourages me to make that goal around exercise, range of motion, things of that nature that sometimes I slack off on. It reminds me, hey, instead of grabbing the dessert when you're wanting something sweet, let's keep some fruit around. It's those personal goals that I get a chance to work through every single time. And what helps me also then helps not only family and community, but it helps the people that I'm sitting right there with.
You are in a true partnership with these clients. And I think that's our ideal always in OT, but not all of us get to truly be partners like you are. That's incredible to
Hmm.
hear.
And it's fun learning. I learn a lot
Yeah.
from participants. And so you talk about keeping up with evidence, even though it's anecdotal. Sometimes the people who come and join the groups have a lot to share, and it sometimes heightens my OT thoughts around and awareness around people's lived experiences. But then it also helps me to affirm my own challenges, and I learn from the
Yeah.
participants.
Yeah. And thinking about this article, I mean, definitely one of my takeaways from it was just in reading about psoriatic arthritis, there's so many different presentations and possible manifestations just in that type of arthritis. And then when you think broadly about how many arthritises are out there, it
Hmm.
just really gives you a sense of the scope of how these diseases can impact people's lives. But I'm really curious to hear your thoughts of what you thought of this article. What were your initial takeaways
Hmm.
from reading it?
I was surprised, so it's some good information, but I was really surprised that OT was mentioned. And I should not be surprised because it's an article that you're
Yeah.
introducing. However, for people to, as soon as I saw physical therapy, I'm kind of like, is OT going to be there? And sure enough, it was.
Hmm.
And so there was a sense of maybe pride,
Hmm.
like
Yeah.
shock
Yeah.
and pride at the same time, that people are beginning to recognize the value of occupational therapy in many areas, especially with arthritis. So that was there. This idea about the treat to target. I had not heard that language before. However, it connects a lot for me to self-management or self-regulation, right? So that particular piece stood out for me, and it actually allowed me to explore the treat to target a little bit more so that I could discern how to come to the table, let's say with another rheumatologist or a healthcare provider, and to say, okay, we're speaking the same language. How can I be of more assistance to not only your practice, but also to the client? I have partnered with rheumatology before
Yep.
to work with people. So so a lot of good and timely, I think, information was in the article, and um, I was particularly interested in even the medical. I'm sorry, the medicine, pharmacological kind of information that was there. Allows me to know what to look for even when I'm scanning a chart or when I'm talking with people. I have a better sense of what they might be engaging, and maybe even the side effects that I might be prepared to talk through with a client.
I love when OT gets couched in the non-pharmacological plus pharmacological, and you can really see the scope of what the patients and physicians are thinking about and managing, and also the limitations of the medications. Just this morning, I was reading, like, we've made such amazing advances in medication for arthritis, to um, help limit the damage to the joint over time. But people still have these functional limitations. The medication has not figured out that part of it. There's still such a critical
Absolutely.
role for OT. And OT was looked at, like you said, really favorably in this article. I'm pretty sure the evidence for OT was higher than for PT, even. So it was
Hmm.
very favorable to OT and very explicit that OT should be part of that mix.
And I love that. And the thing is that I'm not, I love having this article as a tool.
Hmm.
Right. So when I'm approaching, let's say, a client or community member or a physician or physician group, I like having this as a tool to be able to say, "Hey, I'm not making this up or just trying to, get more people on the caseload or that kind of thing. But this is real. The time that you need in order to do your work, there are other things that OT that we're built
Hmm. Yeah. Yes.
to take that time with the person and help them figure out their daily lives or how to implement some of the things that are being asked of them from the physician. So I like having the article as a tool for the conversation also.
Yeah. It is um, it's a seminal piece, so it carries a lot of weight. And I agree, a great thing to share with colleagues and get the conversation
Mhm.
rolling. Something in the article that was lacking was just what our OT care can specifically look like. So that was something
Right.
I wanted to dive in with you for the next couple minutes and just, I know we won't get all the answers, but I would just love to get in your brain and hear how you approach this care. Um, and start just where we start in OT and thinking about assessment. What would you be thinking about if you're seeing an arthritis patient? What are you looking for? Are there assessments that you like using?
Hmm. So yes, and it all kind of depends on what setting I'm in. I do oftentimes still use the COPM. I do start out with that, getting a sense of how much the person is being affected, as far as their daily activities and community living and that kind of thing. So it's the Canadian Occupational Performance Measure. For those who might not be familiar, I do like using that as a tool, and then depending on what's going on with the person, I might depend on your typical assessments of range of motion and measuring edema because of the things that I want to either increase or reduce. The self efficacy scale is something that I look at because my goal is to have that person feel confident in their ability to manage their condition even when I'm gone. So I want to know how confident they are, if there's something changes there, and just any other performance based kind of activities that people say if they're having difficulty with, being able to actually observe them doing some of those things. So I get a sense of, this is what's going on. And I will say that there were a couple of things when I initially thought about it. I said, oh my goodness, I didn't say anything about psychosocial. But oftentimes when I'm having the interview, I mean, sometimes there's the depression scale or something that I might use, but I'm listening for any signs of depression, any shame that comes along with not being able to do the things that you would expect to be able to do, especially at a certain age. If there's any discomfort with appearance, or any anxiety that's expressed. So I listen for those kind of things. I'm going to throw this in there too because this is what I do, right? I listen for any equipment or adaptations that the person may already be using, or any resources, organizations that they may already know about and they're connected to. I listen for how much they may know about their disease or if they have comorbidities. So it's all those kind of things that, as a part of doing using standardized measures, these other questions are a part of the process for me specifically with people who live with arthritis. So yeah, yeah. I will share really quickly that I had a person before who had no idea. I could see the joint deformities beginning to happen, and she had never had conversations with her physician. She had a diagnosis of rheumatoid arthritis. She had no idea of what that meant for her. So that's why I don't make the assumption that people know what's going on with their bodies, and how arthritis is playing a role maybe in some of those changes.
This reminded me of the conversation I had on the cancer rehab podcast. But so often in OT, we're in this acute care mindset. But when you're working with something like arthritis, I just hear you saying you have to take that extra time to understand where they're at on this long journey.
Yes.
And there's so many components to that. Where are they at emotionally? Where are they at just with their knowledge of the disease process? And that's a lot to take in, but I also hear you saying those things and I'm like, these are all OT things. Like it's not a completely different skill set that you're talking about. It's just we need to come with a different mindset to our skill set almost.
Yes, because if you think about it, even if there's something else that's acute that's going on, um, what often happens is that you're going to possibly have flare ups, or maybe that there'll be a progression at some point that you as an OT understand that about the disease and the person does not. If we can do that with people who have other diseases such as multiple sclerosis, right? If we can do that so comfortably with other people, there's space for us to do that with people with arthritis. If they are living well, great, right? There's some health promotion kind of things that we can do to help people to stay or maintain that function as much as possible. But a lot of times when people come to us, they're flare-ups, they're things that are happening. And if we discount those things, it's harder to get to some of the other things that are happening with other diseases. They can't really separate them.
So those are some of the things going on as you're thinking about assessment and trying to place where they're at in the journey. As you're thinking about treatment, what do you see as some of the main considerations you would have in your head as you were planning a treatment? Are you practicing things? Are you goal setting? What's some of your main tools that you would go to?
All of the
Yeah.
above. So, um, depending on what the person needed to do and what kind of arthritis they have and what progression looks like, why they're coming to see me, all of that, right? That gives me an idea of, yes, a lot of times I will go to more performance-based things in order to see how are they already using their joints? What have they figured out that works well? Right? And something, and where are points of intervention where they start to have trouble that I, as an OT, may be able to offer suggestions about adaptations or modifications to something. You make decisions with the person about whether or not they want to spend their time doing certain things. So, are they going to have someone help them? I mean, a lot of these things are very similar to what we would normally do, but lifestyle change is something that's a big part of it, and not just talking about it, not just educating, but also helping the person to look at their day and say, okay, where are there opportunities to make these changes if those are changes that you say that you want to make? And so we do a lot of problem solving, resources, especially things that are free. So there are programs that are available. There are places like the Arthritis Foundation, but helping people to walk through those things, even joint management, and if there's splinting or edema management or modifying how people do things so that they're using larger joints and not and knowing how to exercise knowing the how to do it, how so that you aren't actually going to send yourself into a flare up. Pacing. So there's a lot of pieces that are really talking with the person and helping them to manage. But I also believe in having those performance based pieces also. We can see things sometimes that people cannot see for themselves. And again, some of those things may be strengths that they're doing well that you want to encourage them to
Yeah.
keep
Yeah.
doing.
Yeah. Hearing about that occupation centered lens that you're talking about feels so OT, so in our wheelhouse. I see most OTs being really equipped to do what you're talking about. Um, Something I thought about in the article and I wanted to talk about too was also our role in being a support in these other non pharmacological interventions for these patients, which sometimes OTs dabble in, but maybe we don't think of as our bread and butter. And I wanted to start by just asking about medication management and if that's something that you've talked about explicitly and with clients and how you go about that.
Yes. So, medication management is a huge part of the process. And again, if people are doing well, that's great. But if they're struggling in any way, so I will check just from as basic as can you open your bottles? For some people, if they already have some deformities, that's an issue. So, can you access and open the medications? And I just want to make sure that there's no other, I guess, comorbidity happening where you're forgetting your medicine, right? So, starting with the basics and then getting a sense of how much of a command that person has with managing during the day. Are you following how it's prescribed? If no, are there ways that I can help? So, do you need work in managing or different tools like the pill boxes? Or if those are too hard, there are pill boxes that open on command, voice command, right? There's just all kinds of things of that nature when it comes to medications that I will focus on. Are you clear on what medications you're taking and what their functions are? And what they're supposed to help you do. And so if not, how to make sure that the portal is updated or how to access that information. How to manage your symptoms related to the medication. Is it helping? Are you having more side effects that actually affect your day-to-day functioning? Are you keeping that in a symptom diary? So let's work on that. And what are the key things that when you go to your doctor's visit that you want to have addressed before you leave there? Can you wait to the doctor's visit? Then what do you want to call and ask them? Right. So there are all these things that to me go along with medication management. They're a part of lifestyle, um, I guess, lifestyle management and choices. And those are things that OTs can actually, when we talk about performance, not just telling them, but doing it in the moment if necessary. And also, you'll know your person. You'll know cognitively if they can set a goal around something that they think is important with medication management, and if they can go off and do it and come back, and you can monitor it versus what things you actually need to perform in the moment. But I think we have those options there as
Yeah.
OTs.
Yeah, I'm really interested in medication management. There's so many different components that you just brought up. I hope to do a full podcast on it sometime soon because there's so many components to it and so important for this population and for many of the populations that we see a huge opportunity for OTs to be involved, whether we're the lead on it or we're just like a supporting figure there
Right.
too. Also, drawing from the article, they talked about smoking cessation and weight loss. And for myself, in my skill set, that's something that I never talked about during my OT career.
Hmm.
I guess feels intimidating to me because I know, like, oh, there's really specific smoking cessation protocols out there. But for you, is that something you've touched on? And what do you see OT's roles in those two areas?
So, in my opinion, there's a lot
Yeah.
going on. I don't think I don't think when I go back and I think about my educational experiences, I don't think we talked as much about our role
Yeah.
in weight
I would agree with that.
management, right, and smoking cessation. So there's a couple of things that I think about. One is that if we're asking, I think about smoking and sometimes even the way we eat. Some of it's cultural,
Hmm.
some of it's coping mechanisms. And if we're talking about taking those things away, what were they helping the person to manage? Is there another coping mechanism that we need to make sure is in place as as you're working on things like that, or at least having the conversation so you can refer them back to other professionals. But I'll and I'll say this before I separate them. When you think about it, a lot of times, something people smoke so that it keeps them from eating.
Yeah. Hmm.
So if you take that away, how can you lose weight? There's so much involved in that. So having those conversations with people and getting a sense of maybe if they're even aware of why their eating habits or the smoking is important to them, then it helps us to pinpoint, okay, and the person needs to make the goal. All the goals need to be something that the person comes up with and they're willing to do and that we can support, right? But helping people to figure out weight loss is not something that we perform. There's something you need to do to get to weight loss or do to get to your smoking cessation. Are you on a program? Have you already been given recommendations that you have found it difficult to implement? Do you want to work on those things? Great. Then let's talk through what can you do in the next week? What are you willing to do that take gives you a step in the direction, right? And so that starts to take occupation and goal setting and problem solving, and it allows the person to take steps towards the changes that they're being asked to do for their health. And yeah, it just when I think about that, prescriptions and if people can even figure out what time of day they need to take it that works for their lifestyle, like all of this is very individual work. Yeah. So I guess those are things that I tend to do from an OT perspective in order to work on those things. If those are key components of not only what they want to do, but also helping their symptoms.
I can tell just from hearing you talk that you are very good at asking good questions and then probably supporting that problem solving. Just as you're thinking out loud, I can hear that part of your brain igniting, and that's a skill that I can just tell you've honed over lots of groups, and is an inspiration
Lot
for me to hear for sure, because that is the most powerful thing we can do lots of times is ask the right question and provide that problem solving support, whether it's an occupation and meaningful occupation we're supporting, or if we're thinking about smoking cessation, we can use that tool set that I see you exemplifying in all these
and it's
areas.
so OT.
It's so OT, yeah.
No, thank you. It's so OT. It's so OT. It took a while for me to be as comfortable with it because again, it's not something that's necessarily taught in school. It's kind of like the article. OTs are good at all this and all this and all this. And then you ask the question, okay, so
Yeah,
how?
yeah. What does that look
How do
like?
we do
Yeah.
that though? Can you walk me through that? And but it does, and it's a self-efficacy thing, I think, on our part. Are we confident that we are using occupation-based measures even when we are talking with people and helping them to problem solve? Are we confident that that's an important skill set and that it's okay for us to use? When we get that confidence, it's amazing. I think what the potential that we have to help people to live strong and healthy and equipped lives. outside of the medical setting or the working with the health provider.
Yeah, this article and thinking about the realm of self-management, the potential for long-term impact you can have on someone's life is just incredible and humbling. And I do think OT should have a lot of confidence. And I'll link to some of the tools we've talked about. And there's lots of research out there
Yeah.
for OTs working in this area, which leads me to one of my big picture questions that I had after this article is what I feel like there are not enough OTs involved in arthritis care, at least from where I sit in the United States.
Mhm.
So my question is, why is that? And how do we get more involved? The big
I
question.
will tell you. Yes, it is a big question. And I will tell you that even when I was beginning to have issues at a younger age, um, I think we don't get involved as OTs in arthritis care as much because it's so normalized. My running joke is old Arthur. When I was growing up, I grew up with my grandmother and her sister, and yeah, everything was oh aches and pains, old Arthur. It might not even be arthritis, but that's what they would attribute it to. That was um, a normal part of aging. Everybody's going to hurt and their joints are going to bother them, and we just have to live with it and move on. And that's the part that I said, "Oh, we've got to have a different narrative than that because so many of us, especially as we start to develop symptoms at a younger age, think about the disability that is occurring in your your working aged people and what that looks like for employers and for employees. And so I think we do have to take a bigger role as OTs and to not limit ourselves to only splinting. Huge piece of it, right? But not limit ourselves to the biomechanical, but to use that to get to occupation and to not limit ourselves to joint replacements. I think we kind of have that down pat, but there's so much more impact that can happen for people, and so it's important for us to consider arthritis in and of itself, especially with there being so many different varieties of it. If there's whole rheumatology departments,
Yeah, yeah.
which means right, and so that may also look like being connected and involved in primary care. I did have the pleasure of working with primary care with rheumatology for a while. I was their in-house OT. So there are opportunities, all kinds of opportunities that occupational therapists can engage in, and I do encourage for our eyes to be opened in that
Yeah.
way.
And that fits so well with we're headed into this new realm, at least here in the United States, of an emphasis on value based care and seeing these patients so much earlier than we have been historically. I think there's such a potential for to deliver high value to hopefully help either maintenance where people are at or prevent some of the worse joint damage that can occur. And I love your suggestion
Hmm.
of talking to primary care doctors, knowing who the rheumatologists are around you. And a lot of that is just networking, personal connection building.
Right, right. Absolutely. Absolutely. It does help. And then you get a sense of who's all physicians aren't necessarily as
Yeah.
focused on what life looks like for the
Hmm.
person, right? There's a lot of managing the condition and trying to get the pain and the swelling and that kind of thing. Um, right, yes, but not as much focus on. So what do they do when they leave
Yeah.
here?
Yeah.
And so yes, it's a great connection for people if they have that interest to help people to put it all together and to be able to circle back and make sure that that office knows the value of what's been happening.
Yeah, and those more in-depth questions I hear you asking, lots of times physicians just don't have time for that during their visit. And maybe they want to ask those questions and they're constrained. So it can be such a
Absolutely.
beneficial partnership there.
Absolutely. It's the desire a lot of times and the restraints that come with practicing. And we have our own constraints, right? We know we have our own constraints. And so, but when we partner, we can help each other to get all of that information and then along with the participant or the client themselves and to do our best with the time that we have with
Yeah.
them.
I have one more question I wanted to be sure to ask, and it was about health tech tools and keeping up with new technologies that are coming out. I assume there's health trackers and all this adaptive equipment, which in all areas of OT practice, there's just more and more supports coming out. How do you keep up
Yeah.
with what's happening in the arthritis world, or any specific examples of what we should be watching?
Oftentimes, I will start. I'll just put it out there. I'll start with the Arthritis Foundation. I will start just to see if there's anything there. And most people may not be at the age that they can do this, but you'd be surprised what kind of tips and tools, tech tools, come in the
Oh,
AARP.
yeah. Yep.
In their newsletters and different things, incredible. Just lots of ideas about technology. And when I say that, I'm talking about things that are even voice activated locks and phones and just I've even saw something where there's voice activation for helping to tie your shoes.
Oh, my goodness.
So that if you don't, and it's not even that expensive, but if you're not able to tie your shoes, but you don't want the shoes, because again, remember psychosocial shame, different things that can come along with arthritis. And so just all kinds of ideas of voice activation and how you can manage those things. So I thought that was interesting. One thing that I don't think we use as much as OTs is that, modalities, because for many reasons, right? When we think about occupation. However, if a part of a person's lifestyle is to incorporate maybe the right amount of heat at a certain time, and so even I was laughing, even the heated blankets, using it in the morning to kind of get yourself ready to stretch out just a little bit so that once you stand up that you can actually move, because not being able to move in the morning is a real thing.
Yeah. Yes.
So it's a real thing. So and just those are the things I think of. Also, Arthritis Foundation has this walking program that's accessible to people. And so there are apps, different ways that you can track your symptoms, that you can um, even manage your goals, your walking goals, as a way to kind of fight against, if you will, the symptoms. So, I mean, and those are a lot of the things that come up. So if it is an OT, if you're struggling and you just even Google it, you will see so much can openers and just all kinds of things that are there that are not any more expensive than anything else that you would get for yourself if you didn't have any disability at a store or on Amazon. So, while I don't have anything super specific, those are the kinds of things that, and I think the between AARP and Arthritis Foundation, some of those places have been the ones that will keep you aware of the technology changes a little bit faster.
All that just fits so well with, well, I feel like is almost the theme of our discussion today. There's so many tools out there for us as OTs, that have already been packaged and researched for us by the Arthritis Foundation or these different articles. And this all fits so well with our OT skill set. And there's a huge need out there of these many, many people with arthritis on all stages of the journey. It's really, to me, an important call to action to become more involved to expand our services in this area. And I just love being able to hear about your career and how you've done this already. And it's just so fun to hear. I feel like I'm getting to hear how your brain works during these groups and the great questions that you ask.
Indeed, indeed.
I'm like, this is a person with a lot of skills honed over lots of years.
Thank
Oh,
you.
we're already at the end of our time. I want to ask you just one of my rapid fire questions, though, which is we've talked about so many things today. What has stood out to you as one of the most important things, or what you want to leave us with?
I want to leave the audience with this notion that that OT does matter when it comes to a lot of things, but even especially with arthritis and well, all types of arthritis, that we shouldn't take our time with people for granted. There's so like we normalize the disability to a certain extent with people with arthritis, and to be able to actually sit and say, okay, if they're fine, that's great. If not, I have a role in this, and I'm not going to just pass it by, but I'm going to make sure that if this person wants to engage in some changes that might help them live better or live well with arthritis, then that is what I'm going to use my time for, and I'm justified in doing that. It's that kind of thing that I really want to put out there, because I think it allows us to dig a little deeper than some of, again, stopping. Biomechanical is important, but stopping there is all the time is not, I think, the end goal for us. And being able, so I'm just really encouraging people to take that moment with somebody and to make sure that they're okay before we jump into other areas, and not to forget about those people.
Well, Duana, you have been such a role model for us in how to do that. I so appreciate your time today and just being able to hear how you're processing things and see that skill set that you've built up over the years and how you've been able to really partner with your clients. That's such an inspiration and such a great model for us. So thank you so much for sharing all your knowledge and wisdom today.
Thank you. Thank you for having me. It's every time I do something like this again, and while I'm sharing with people, I also learn. So thank you for your work.
Wow, you all, I just love this time with Duana. You can tell that she has really made this career of partnering with her arthritis clients, and I hope that this course helps more OTs do the same. As I mentioned multiple times throughout the episode, there are so many resources out there for you to leverage with your arthritis clients, and I will be linking to lots of those in our show notes. I also wanted to highlight a brand new 2023 article which supports higher rehabilitation doses to improve physical function in adults with RA. Rheumatoid arthritis is definitely where we see a lot of the groundbreaking research happening for arthritis, so I definitely encourage you to check out this article. I also wanted to remind you that if you are interested in earning a certificate for your time today, what you are going to do next is head to otpotential.com, where you can sign in or sign up for the OT Potential Club. And as always, I want to thank you so much for joining us today. I hope this podcast helps you broaden your knowledge, tweak your practice, and stay evidence-based. Take care, and we'll talk with you next time.